From Charleston, South Carolina again. We have Deanna DeHoff, who will be talking about a single-center descriptive overview of pediatric burn patients treated with a bromelain-based enzymatic debridement.
My name is Deanna DeHoff. I am the research coordinator at MUSC, South Carolina Burn Center. Today I'm going to be talking about Nexobrid for our pediatric patients. So everyone has seen Dr. Khan's disclosure slide many times already, so I'm not going to go over that one. Courtney talked a little bit about this earlier. We've also heard how tangential excision and autografting donor sites are historically burn care. One of the drawbacks of tangential excision is that it naturally removes healthy tissue in addition to the eschar, minimizing chances to heal with skin grafting. Split thickness skin grafts create a painful donor site secondary to the burn wound as well. So you've also heard what bromelain is many times during this conference, but for those of you who have not heard one of Dr. Khan's many talks or Courtney's about 20 minutes ago, it is a proteolytic enzyme found in the stems of pineapples, acts as a minimally invasive enzymatic debridement. Literature has shown multiple benefits, such as faster time to complete eschar removal and the reduced need for skin grafting. Approved for commercial use in 2022 for adults and pediatrics in 2024, bromelain-based enzymatic debridement has proved useful. Real-world experience using bromelain-based enzymatic debridement in pediatric patients is what I'm presenting you with today. So this study was a single-center retrospective chart review of pediatric burn patients treated with bromelain between September of 2021 and April of 2025 at an ABA-verified pediatric burn center. Patients in the NEXT trial and commercial use patients were included. We extracted pain management, medications, burn characteristics, demographics, and procedures. And we calculated the length of stay per 1% TBSA and benchmarked the value against the burn care quality platform average length of stay, which was 3.3 days per 1% TBSA. So I'm going to go through some of our institutional protocols, pain management protocols, some results, and a case study and future directions. So first on our institutional protocols, the dosing for all ages is 2 grams of enzyme per 1% TBSA. Up to 10% body surface area can be treated in patients under 6 years old, and up to 15% body surface area can be treated in patients from 6 to 17 years. Pre-treatment, afternoon or the night before, we verify all orders for medications and labs placed. I know that we're currently working on an order set for Nexobrid for our pediatric patients. So that is on the way. We avoid all use of silver or iodine-containing products before the day of treatment. About 2 hours before the procedure, we make sure the wounds are thoroughly clean with soap and water and dress with hypochlorous acid or quarter-strength Dankins soaked gauze dressings, and this is used to decontaminate wounds and prevent bacteremia. About 30 to 45 minutes before, patients placed on a monitor, and pre-medications are administered depending on the pain management method of choice. Moving to the day of treatment, about 15 minutes before the procedure, dressings are removed, wounds are then washed again with soap and water. We take a lot of photos. Applying the enzyme, we do the thick petroleum jelly border. The enzyme is mixed and applied 3 millimeters thick like cake icing. We're wrapping it up with 10-10 sheeting and a light gauze wrap, securing the edges to avoid leaking. And this is our setup for an 8-year-old female scald burn. She has the thick border and the cake icing enzyme. It's not spread out in that first picture, but it's getting there. 10-10 sheets on the borders to help keep it in place with tape. We want to ensure it's not too tight or not too loose. You don't want anything coming out, but you don't want it too tight either. So during the 4-hour treatment period, we have frequent check-ins. It's very important for pain management and to ensure the wounds are secure. For removal, we use a blunt object, such as a tongue depressor, used to scrape dissolve eschar, and they're washed again with soap and water and dressed in saline-soaked dressings for another 2 hours. Dressings are removed and redressed with antibiotic ointment and petroleum impregnated gauze. If they're not going to the OR the same day, we want to keep it as moist as possible and put it in a thick layer of surfactant gel or antibiotic ointment. Basically, we want to put it in something that's not going to desiccate the wound or dry it out, and we avoid anything silver or hypochlorous acid after treatment. So our pain management protocols, which is very important, especially in peds, We have two pathways, one where they're more awake, like oral ketamine, peripheral nerve block, and then one of the other pathways for our larger burns, which is IV ketamine, or if they're on a vent, they get propofol, Precedex. Adjunct narcotics and additional medications are administered for agitation and breakthrough pain. So where does this take place? Most of our patients go to sedated wound care and hydrotherapy suite. Patients that have the enzyme applied in the hydrotherapy suite are transferred back to their room in the ICU for the duration of treatment, and it can be applied bedside or in the operating room with concomitant procedures. So the results of our study, we included a total of 13 patients, median age of 11, saw a range of age of 2 to 17 years, 8 males and 5 females were treated. The median burn size was 7% total body surface area, with about 1% of that being full thickness injury. The average length of stay was 20.8 days, and the ratio was about 2.6 days per 1% TBSA. The etiology was variable. The most common type of injury was flame. The second was friction. Yes, this can be used in friction injuries. Scald and contact were also included. As you can see, these are much more complex burns. The normal distribution of etiology for pediatric patients is not normal in this study. And then it is mentionable that we had one readmission, but this was not wound-related, and no deaths were observed. So the enzyme was applied on 8 patients with sedated wound care and hydrotherapy suite. These patients were already sedated with ventilation or treated with oral ketamine before they were taken hydrotherapy. The nerve block was done while they were sedated in hydrotherapy and then brought back to their room in the ICU where they needed less medication during the removal. Pain management-wise, ketamine was used in 69% of patients and nerve block was used in 33% of patients. Lorazepam was given as an adjunctive to those dosed with PO ketamine, and to manage breakthrough pain, these patients were given additional narcotics and anxiolytics. So all 13 patients had a surgical procedure, but we do not do surgery on every pediatric burn patient. But because these were all larger, complex burns, all of our patients went to the OR. Most patients had one procedure during their admission. 85% had skin cell suspension autografts applied. 62% of patients had a split thickness autograft applied. 62% had a skin substitute applied, like allograft or polylactic acid sheet. So time to initial operation after the treatment, all patients went to the operating room within 24 hours of treatment. 46% of patients went to the OR the same day. And we observed a shortened length of stay per TBSA in these patients versus the BCQP national average. We saw no readmissions for wound complications. And with the right protocol in place, you can do this in the morning and take them to the OR later that day. So I have a quick case study. This is the same setup that I showed earlier. So it's an 8-year-old female with a scald burn from boiling water. No pertinent medical history, otherwise healthy child. She had a 6% TBSA. About 1% of that was full thickness. The first picture is her initial injury before debridement in the ED, and then the second picture is her initial debridement in the emergency department, just washing with soap and water. So after the enzyme, she received oral ketamine and was treated bedside in the PICU with the enzyme. She received skin cell suspension autograft on the same day as enzymatic debridement. So before the scraping is the post-treatment dressing removal, and then post-scrape is that second photo there. Obviously, it shows how deep the burn is afterwards. This is also before we soaked with saline and she went to the OR. So follow-up, this is 2 weeks post-treatment. These photos were taken in clinic. She had already been discharged. She was 99% closed with pigment returning. You can see her skin cell suspension autograft donor site there on the very bottom corner. It's super small compared to the rest of her burn. Had we not done Nexobrid and the skin cell suspension autograft, that would have been much larger. So future directions. Combining data from this descriptive study and previous literature, a national protocol for this treatment can be published to efficiently and safely treat pediatric patients in the future. Bromelain is a feasible escharectomy option for pediatric burn patients, and the 3 photos underneath are showing you another successful case of a 5-year-old male with a friction burn. So all the way to the left. These photos, it's his before, pre-treatment, post-treatment, and then his 3 weeks follow-up. So that patient received a peripheral nerve block and got split thickness skin graft and skin cell suspension autograft the same day as treatment.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.